You know that sound? A sudden impact, a sharp crack, and then a trip to the ER. A broken collarbone is one of those injuries that's just incredibly common, happening to everyone from pro athletes to kids who fall off their bikes. In this explainer, we're going to dig into what exactly happens when this really important bone snaps.
And I'm not kidding when I say common. The clavicle is legitimately one of the most frequently broken bones in our entire body. It's got that gentle S-curve and sits in a pretty exposed spot, which, makes it super vulnerable to impact.
But what really goes down when it breaks? Because it's not just a simple crack. It's actually a pretty complex injury. You've got muscles, ligaments, and all these pulling forces involved. So let's follow the journey, right from that moment of impact all the way through the road to recovery.
Okay, so to really get a handle on the fracture itself, we've got to talk anatomy first, because it's all the stuff around the clavicle that really determines how a break acts and ultimately how you need to treat it.
The absolute key to understanding pretty much any clavicle fracture comes down to these two little structures, the coracoclavicular ligaments. We just call them the CC ligaments. I want you to think of them as these super strong anchors. They are the main stabilizers holding the clavicle down, and whether they're intact or not is pretty much everything when a doctor is sizing up a break.
So, the second that bone snaps, this dramatic tug-of-war kicks off inside your shoulder. You have this big muscle in your neck, the sternocleidomastoid, that yanks the inner piece of the bone upwards. Meanwhile, the weight of your arm and your pec muscle are pulling the outer piece downwards. That is exactly what creates that classic, obvious bump that you can so often see right through the skin. So where do these things tend to break? Well, it's not totally random. The huge majority, we're talking 80 to 85% of them, happen smack dab in the middle, in the midshaft. Breaks at either end are way less common, but a breakout near the shoulder, at that lateral end, that one comes with its own special set of problems.
Right. So once someone gets to the hospital with a suspected fracture, the doctor's #1 job is to figure out just how bad the damage is. And this whole assessment, it's absolutely crucial for deciding what happens next. The physical exam is basically a 3-point inspection. First, they look at the deformity. There's a sharp piece of bone pushing the skin up into a little tent. We call that tenting, and it's a huge red flag that the bone is about to pop through. Second, they check if the skin is already broken. And third, and this is a big one, they check the neurovascular status. See, the main arteries and nerves for your whole arm run right underneath the clavicle, so any damage there is a really serious problem.
Now, for those less common fractures out by the shoulder, doctors use this specific system called the Neer classification. So a type 1 is stable because the break is outside of those super important CC ligaments we just talked about. A type 3 actually goes right into the shoulder joint, but it's type 2 that's the real problem child.
And here is the money shot. A type 2 fracture is where the break happens medial to the ligaments, where the ligaments themselves are actually torn. This means that main piece of bone is basically floating free. It's not stabilized anymore. It becomes unstable, it moves around a lot, and it has the highest risk of not healing on its own. That's what docs call a non-union.
So, besides just being a type 2 break, doctors are on the lookout for other red flags that suggest a bone is going to have a hard time healing. Is it way out of place or shortened? Is the bone shattered into a bunch of little pieces? We call that comminuted. And other things, like being an older female or being a smoker, can also raise that risk of non-union.
So all of this assessment, all these factors, they all boil down to the single biggest question for both the doctor and the patient: do we need to do surgery, or can this thing heal on its own? This is the great debate in treatment.
You're basically looking at two paths. For breaks that haven't moved much, the standard is non-operative treatment. This is just a sling, basically, for comfort. The bone almost always heals, but it often leaves a pretty noticeable bump behind. For fractures that are really displaced, surgery can put the bone back together perfectly, but of course, that comes with its own whole set of risks. Now, some situations are just totally non-negotiable. These are what we call the absolute indications for surgery. If the bone is sticking out of the skin, if there's damage to an artery, or if that skin tenting is so bad that a breakthrough is about to happen, surgery is the only real choice.
But most cases actually fall into this gray area, the relative indications. This is where the decision becomes more of a conversation. Let's say the collarbone is shortened by more than 2 centimeters, or the two ends are completely apart, or if the patient is a young, active person with a really shattered fracture, then surgery is often recommended to get better long-term strength and function back. Okay, so if surgery is the chosen route, what does that actually look like?
Let's take a quick peek at the techniques surgeons use to put all those pieces back where they belong.
The most common way to do this is with a plate and screws. A superior plate, which goes on top of the bone, is mechanically the strongest. The problem is there's not much padding over your collarbone, so you can often feel the hardware right under your skin. An anterior-inferior plate goes on the front, so it's less noticeable, but the surgeon has to cut through part of the deltoid muscle to put it there. So, you see, each one has its trade-offs.
And that annoying hardware is a real thing, especially for people who wear backpacks or carry heavy stuff. It's so common, in fact, that about 30% of all clavicle plates end up being taken out in a second surgery, just because they're bothering the patient.
All right, so whether you had surgery or not, the last part of this whole story is the recovery. And this phase has its own timeline and, especially after an operation, its own potential issues.
So, the typical road back involves being in a sling for a few weeks, mostly for comfort, then slowly getting your motion back. The big milestone is usually around 3 months. That's when patients are told to steer clear of any contact sports. And like we just mentioned, for folks with plates and screws, that 1-year mark is often when you might start talking about getting it removed.
So, what are the most common bumps in the road after surgery? Well, while annoying hardware is the #1 reason people have to go back for a second operation, the single most common complication overall is actually something else. It's numbness, right below the collarbone.
And the reason for this numbness is just anatomy. You have these tiny little nerve branches that fan out directly over the top of the bone, right where the surgeon needs to work and put the plate. It is incredibly hard to do the surgery without stretching or even cutting some of these little nerves, and that's what leads to that patch of numbness on your upper chest. It's a super common and often permanent side effect.
So, from that first crack of the break to the final stages of recovery, the story of a clavicle fracture is all about trade-offs. You're balancing a permanent bump against a surgical scar, the risk of the bone not healing versus the risks of surgical complications. And it really leaves us with that ultimate question. In a situation where there's no single perfect answer, how do patients and doctors work together to navigate all these complex choices and find the path that's right for them?